Good morning. We'll be talking about evaluation of common fractures. So we're going to review characteristics of pediatric bone and the fractures that occur in the pediatric population, overall treatment, evaluation, and management of these fractures, and then also recognize patterns associated with child abuse. I hope some key points that you take away and take to your practice are these things here. So one is always obtain at least 2 view x-rays of the area of concern so you don't miss an injury. That this list of fractures is ideal to treat in your practice if you feel comfortable. And then kind of urgent referral of physeal fractures or fractures you think need surgery by a pediatric specialist. So fracture rates are increasing. There are 2 reasons for this. One are more and more children are actually involved in sports, and sports are getting more competitive at younger ages, and so that leads to increased injuries. And unfortunately, the other thing is that obesity rates are increasing in children, and we know that obese kids are more likely to sustain fractures than kids that are of normal weight. There's a male predominance, so about 40% of boys and about 25% of girls will sustain a fracture by age 16, and almost a third of these may involve the growth plate. Pediatric bone is very different than adults. It is much more porous, so you can see that these kind of holes within the bone, and that porosity makes it more flexible. It also has a very thick lining, hold on, right here, and that thick lining acts as a tube around the bone and is much more robust in children. And then, of course, growing children have a growth plate, so the physis, and that is an area of weakness. So all of these characteristics lead to different fractures in children. And what are some of these fractures? So there are buccal fractures here, where you see just a malcompression of the bone. You can have plastic deformation, which is kind of a gradual bowing of the bone. Green stick fractures, which are incomplete fractures, and again, that's because that periosteum is so thick. And then kind of a very severe physeal fracture, so a fracture that goes right through the growth plate. And we'll review these a little bit more in detail. So the physis is made up of cartilage, so it's this nice thick white zone right here, and so you have bone above and bone below. But this area of cartilage is an area of weakness, but it's also responsible for the longitudinal growth of the extremity. And so just to review the Salter-Harris classification. So a type 1 is an injury right through the growth plate. A type 3 starts at the physis and then goes to the metaphysis. And this is the most common. About 75% of physeal fractures are type 2s. Type 3s start in the physis and then go to the epiphysis. So these are articular fractures, meaning we can't really accept significant displacement because that'll lead to arthritis in the future. Type 4s involve all 3 zones, again, a high rate of growth arrest. And then type 5s are very rare, but they're a crush injury to the growth plate. So I know we have this polling system. So what Salter-Harris fracture pattern is this? You're close. So actually, it is a Salter-Harris 3 fracture. So, this starts in the physis and goes to the joint surface. So that's a Salter-Harris 3. So the physis is both our friend and our foe. So it's our friend in that it allows this process of remodeling, where the bone can be crooked and then over time, with growth, it straightens out. So this process happens because when the physis is angulated, so the physis always wants to be parallel to each other. When the bone heals and it's angulated, meaning the growth plates are not parallel to one another, it will cause more growth on one side and less growth on the other to allow over time the bone to remodel. So in this 6-year-old who had this very displaced fracture, with no treatment, in 6 months, it's relatively straight because the growth plate wants to become straight, parallel to one another. And again, we can see this process here. This is a 4-year-old, very badly displaced proximal humerus fracture. Over the course of a little over a year, the bone is relatively straight. This process is much more robust in younger patients. So in kids under age 10, this is a very kind of reproducible, we know this is going to happen, we don't have to worry about these fractures. It's also much more robust closer to the growth plate. So a fracture here is going to remodel much faster than a fracture in the mid-shaft of the bone, because of its location. The physis can also be our foe. So damage to the physis can be irreversible. So those type 3 fractures or type 4 fractures that involve the growth plate and there's some malalignment, the bone is then going to heal and the physis is disrupted. And so a deformity at age 5, as the child grows, becomes much worse by the age of 12, where you can see the ankle is very, very crooked now. And so that's something where, we want to intervene and do the best treatment we can at the early age to potentially avoid something like this as an outcome later. So when patients present with concerns of a fracture, you initially want to just talk about the mechanism of injury when you're getting your history. Because of course it could be a low energy injury where it's just a fall off the couch. It can be a higher energy injury like a sporting injury, and then a motor vehicle accident where you want to assess if there's been any loss of consciousness. If the mechanism is unknown or unwitnessed, always keep abuse in your differential. And we'll go over some other characteristics of that as well later. So signs of fractures, there's going to be localized pain. So not diffuse pain, but pain to a specific area. Swelling and warmth to that area as well, because there's going to be increased blood flow, and that's going to cause that warmth and swelling. And then kids are smart. They're not going to want to move their arm because it hurts. So how do you go about examining them? So on the very young patients, I think it is ideal to place them on the parent's lap. They're going to feel more comfortable, a little bit safer. I always start with asking them to do their own range of motion. So what can they do comfortably? What can they demonstrate to you comfortably? And then go on to doing passive range of motion. Also assess their neurovascular exam, and we'll go over that in a little more detail in the future slides. And then always start with the unaffected side first. Feel for warmth, swelling, so you have an area to compare to. And then once you find your area of tenderness, if it's your forearm, be sure and focus on the joints above and below so you don't miss any other associated injuries, because you can have multiple fractures. So for your upper extremity exam, wiggle your fingers, wiggle your toes. It's not a good exam, and so I want to just give you some kind of thoughts on how you can isolate things. So rock, paper, scissors is really good for the upper extremity. So rock, if you make a fist, that's finger flexion and thumb flexion, and that's your median nerve. And then isolated sensation is going to be at your index finger. Paper is radial nerve. So extension of your fingers, extension of your thumb, first dorsal web space for your sensation. And then ulnar, or scissors is going to be ulnar. So abduction, adduction of your fingers, and sensation to your small finger pulp. So that's an easy way to examine the kids and know that everything is intact or what is not intact. For the lower extremity, I don't have a great mnemonic. So for your femoral nerve, you can check your quadriceps, which is knee extension, and then sensation on the anterior aspect of the knee. For your tibial nerve, it's toes down, plantar flexion, and sensation is on the bottom of your foot. Then you have your superficial and deep perineal nerves. So for your superficial perineal nerve, it's going to be eversion of your foot, and then the sensation is right on the dorsum. And then for your deep perineal nerve, it's going to be dorsiflexion, or bringing your toes and ankle up, and sensation is going to be in that first web space. So who needs x-rays? You don't want to get x-rays on every bump or contusion. You want to get x-rays appropriately, not expose patients to excess radiation. So if there's obvious deformity, then it's clearly needs an x-ray. If there's any loss of function or the patient's unwilling to use the extremity, I would say that's another indication. And then if they present to you in a delayed fashion and it's been a couple days and they're still having pain, it's an appropriate time to also get x-rays as well. Again, always get 2-view x-rays of the area of concern. So this patient, 7-year-old, has wrist pain, and you get this x-ray and everything looks good. You really need to get your lateral to see that there's a significant displacement at the growth plate. So if you only got the single x-ray, you might potentially miss this. And then always consider x-rays of neighboring joints based on tenderness. So, we tend to focus on the wrist, but if you didn't palpate the elbow, you may not know that they also have an associated elbow fracture. So always look, above and below the area. And also make sure you look at your x-rays completely, because you tend to get focused on this and may miss what's on the periphery. So splinting, you have several options depending on your setting. Some places do have prefab materials like orthoglass here. You can just cut it to size. Make sure if you're immobilizing, the forearm, you want to include the wrist and the elbow. If it's something that involves the elbow, you want to take the splint up as high as you can to get as close to the shoulder. And then just splint them in whatever position they're comfortable in. If you're out on the field or don't have access to prefab materials, you can use pillows and towels, ACE wraps and tape just to temporarily stabilize them until they can get to another facility if you don't have that material available to you. Again, there's no need to do a reduction, just splint them in whatever position they're comfortable in. And then, that prevents any further injury to the area and also makes them more comfortable for transport. So when and where to refer. So if there's significant, and I know you know a lot of this, but if there's significant swelling, neurovascular compromise, and open fracture, those all clearly need to go to the ER because it's an urgent referral and may need treatment in a very quick time frame. Fractures that involve the joint or the physis, or anything you think might need surgery, I would say ideally they should be seen in an office within 3 days. And that's because if they need the injuries that involve the growth plate heal very rapidly. And so we have kind of a small window of opportunity to do surgery or fix those fractures. And so we want to see them relatively quickly. All other fractures that maybe aren't significantly displaced, but maybe you don't feel comfortable or don't want to take care of them, I would say ideally we should see those, they should be seen by a pediatric specialist within about a week. So if you have an open fracture, the way you want to treat it is just to put some sterile gauze over the area and then have further evaluation in the ER. In the ER, they'll get their antibiotics and their tetanus up to date as needed. Make sure and tell them not to eat or drink anything, because even if we're not going to take them to the operating room, they might need a sedation in the ER. And if they have a full stomach, that's a 6-hour delay or more. And so we just want to let them know, don't eat or drink anything. And then if you do obtain images, be sure and try and send those copies with them, not the report, but the actual images, either on a CD or hard copies, just so that we can, again, minimize any unnecessary radiation to the patient. And so these are fractures that often will present to your clinic, and I hope after hearing this talk you feel comfortable potentially managing these patients in your office. So this is the torus fracture, and we've kind of discussed this before. It can be many varieties. So this is a very mild torus fracture, and here below you can see it's a little bit more obvious, a little bit more significant. The thing you want to look at is that the opposite cortex is intact, so it's nice and smooth. These are inherently stable injuries. They're not going to move, and treatment is going to be a removable wrist brace for 3 or 4 weeks. Many studies have shown that these don't need any follow-up x-rays, do not need a follow-up evaluation. We tell the families to remove the brace when they're pain-free, usually in 3 to 4 weeks. The only thing is you need to be able to stock appropriate sizes for pediatric population. And if you manage these patients, it's a huge cost savings to the family. They don't have to make another appointment with a specialist. They don't have to take off time off work, off school, pay for parking at some other location. So I think families are very, very appreciative to have you manage these. And if you end up putting the splint on them and then refer them to our office, we have actually nothing to offer them, and families get a little bit upset at that also. Oh, why am I seeing you? So I would say you should always do what you feel most comfortable, but this is a really good fracture to be managed in your office. So I want to distinguish that from this fracture. So this is plastic deformation. So again, it's an incomplete fracture, but there's a gradual bend. Oftentimes, all these injuries, are a fall onto an outstretched hand. This may happen on the playground. They may notice some swelling, and they may seek treatment immediately, or they may not. And then a few days later, they notice the swelling's not going away, and it's actually a permanent kind of deformity of the arm. This is very different than the torus fracture. And so these, actually, for whatever reason, the growth plate is close to being parallel to one another, so it doesn't want to remodel. So this curvature of the bone can potentially be permanent for the family and the patient. And so these are ones that we want to see, because those we have to physically kind of manipulate and take to the operating room potentially to reduce. And we have a very short window, that 3 to 7 day window to do that in. And then birth fractures. So birth fractures can often happen of either the clavicle or the humerus. It's associated with a larger baby, a difficult delivery. There can be associated brachial plexus injury with it, so you always want to kind of monitor for that later while you're following them. Initially, the babies are going to have the pseudoparalysis. They're going to keep their arm to their side. They're not going to want to move it. And so you can't really know if they have a brachial plexus injury initially. It would be very difficult. So the treatment is going to be just basically, I tell the families to put the patient in a long sleeve onesie, pin the chest, the sleeve of the onesie to the chest, and it just acts as a sling. The nice thing is that then you're not having this big ACE wrap, wrapping the kid up and down. It causes a lot of pain, and this can just be a very simple form of immobilization that works very well. And these fractures are going to heal in about 2 weeks, 2 to 4 weeks, so they heal very, very quickly. And then after that, the families can discontinue the safety pin. And then you can follow them to make sure that they extend their fingers, that they move their elbow, and make sure that they don't have some kind of brachial plexus type problem. And so clavicle fractures, these are the second most common fracture we see in kids. And so not birth injuries, but the ones that we see in 2 years and older. And so the most common, of course, is the distal radius, and the clavicle is the second most common. The typical mechanism is going to be a fall into the shoulder. They're going to have significant pain, swelling, and kind of a crepitus if you kind of palpate that area. These are almost always treated non-operatively in the pediatric population. The treatment's going to be a sling for comfort. The thing you want to inform the families of is that once the bone heals, there's going to be a bump there because that area is going to have a lot of callus. And the clavicle is so superficial that that's very noticeable. Over time, that callus is going to remodel and it's going to be smooth again. But you just want to counsel them so they're not unhappy with that initial appearance that might be there for 3 or 6 months. Proximal humerus fracture is another fracture that's ideal to be treated, especially in kids under age 8. So we know this physis, this growth plate, is very, very robust. 80% of your growth comes from this area. So any fracture in this area right here will remodel tremendously. And so all of these patients, if they have even a very displaced fracture, our treatment is going to be a sling. and it heals very rapidly, usually within about 4 weeks. If the patient is older, then the chance of remodeling is less. And so those are the ones that need to be seen by a pediatric specialist. And then toddler fractures. So again, always important to get 2 views. You can see this kind of subtle fracture here, but no sign of the fracture on this x-ray. And then a toddler fracture could also just be potentially just a small buccal fracture as well. So these are very subtle fractures. Children usually present with a fall off the couch, or even mechanism might be unknown. It's usually low energy injury, and they're refusing to bear weight. If you get your x-rays and you see the fracture, then you can feel very confident that this is a fracture and you can treat them appropriately. If there's no fracture, that you see on x-ray, it could still be an occult injury, meaning that the bone is injured, but you don't see any true evidence of it on x-ray. Always keep in mind, though, that sometimes infection presents in a similar fashion. So if you put them in a splint and they recover rapidly, then it's clear that they probably had a fracture. If their pain persists or they start developing fevers, let them know that, come back in, we need to reevaluate you, because some of these kids actually don't have a toddler fracture, but they might have osteomyelitis or some kind of infection. So the splint, you can use like a posterior splint that you can make in your office, or you can put them in a cam boot. Again, you have to just be sure to stock sizes appropriate for kids. If you decide to apply it, we definitely prefer the cam boots because they're prefabbed and the patient can get their heel all the way down. If you make a splint for a patient, then sometimes there's not enough padding on the heel, or the patient's left in equinus. This can happen just in a few days, where they get breakdown because there's just not enough padding and the splint slides. And then this problem is actually worse than the fracture that they initially presented with, because this is very, very difficult to treat and manage. So green stick fractures, again, I'm kind of giving you fractures that you hopefully feel comfortable managing, and then distinguishing them from similar fractures. So a green stick fracture is an incomplete fracture. There's that thick periosteum that's lining the bone, so sometimes this will be displaced and sometimes not, but you can see that there's gapping here. So very different than a torus fracture where there's compression. The treatment's going to be in a cast because these can be unstable fractures, and so again, refer to a pediatric specialist. Primarily in this area, you really want to refer it because that fracture can go on to this, where the patient got significant valgus deformity. And that's not because they were treated incorrectly. For some reason, this growth plate is a little bit touchy. So when you have a fracture here, sometimes it just goes on to asymmetric growth. It's called Cosen's deformity. If the family isn't counseled about this early on, they get very, very upset. Again, nothing was done wrong. It will just get worse for about 18 months, and then we'll get better. But we know that, and so we can counsel them on the front end that this may happen, so that the expectations are realistic. And so lastly, we're going to just talk about ankle fractures. So typically this is an inversion injury, so they're going to turn their ankle. They'll have tenderness either at the tip of the fibula or at the level of the fibular physis, which is about 1 to 2 centimeters proximal. If it's an avulsion fracture like this, where it's just a small fleck of bone or just off the tip of the fibula, those are essentially the equivalent of an ankle sprain, and they can be treated in a lace-up ankle brace. If it's more significant and that there's displacement, or you suspect that the tenderness is more at the level of the physis, or even you can see a fracture that involves or goes into the physis, those can still be treated in a boot as opposed to the lace-up ankle brace because they just need a little bit more support, and they'll wear that for about 4 weeks until they're pain-free. And then unfortunately, we should just touch on child abuse and fractures associated with that. So just remember, child abuse can happen in any socioeconomic group. If you see a child under the age of 3, you should have at least, abuse should occur, be in your differential. Mostly because kids under age 1, about 50% of those kids, their fractures are related to abuse. And under age 3, about 30%. And again, femur and tibia fractures are very rare in the non-walking child. So if you see a 14-month-old and they're not yet walking and they sustain a femur fracture, you have to have at least cause for concern because it's very difficult to break that bone. And so on this x-ray, you can see this patient has a clavicle fracture, very young, multiple rib fractures, healing fracture of their femur, healing fracture of their tibia. So you see fractures in multiple stages of healing and as well as acute fractures. This is a corner fracture right here, and so that is a twisting injury. The only way that can really happen is with abuse. So again, I just want to give you classic pictures of what to look for if you're suspicious of abuse. When you talk to the families, the history may be inconsistent, doesn't make sense for this does not happen from a fall. And then we always encourage people to get social work involved because social work can make contact with CPS, find out if they've been traveling to multiple ERs, urgent cares where, trying to avoid being detected. Oftentimes, again, there's a delay in seeking care, so you see, multiple fractures in different stages of healing. And so I just want you to keep those pictures in mind. So that's it.